বাংলাদেশ পাকিস্তান ক্রিকেট
আর আপনার শেয়ার স্লাইডটা শেয়ার একটু আরেকবার করবেন বিফোর দ্য স্টার্ট।
ওকে I don't know, it's resetting right now, so let's see. দেখা যাচ্ছে?
জি স্যার।
দেখা যাচ্ছে?
স্যার দেখা যাচ্ছে।
আচ্ছা,
জি স্যার দেখা যাচ্ছে স্যার।
তাহলে আমি বন্ধ করে দিই।
আমি কি শুরু করতে পারবো?
জি তুষার ভাই শুরু করেন।
আচ্ছা ঠিক আছে।
আমি কি স্লাইড রেখে দেবো না স্টপ শেয়ার করবো?
তুষার ভাই you can start now.
Assalamu alaikum and good evening, respected physicians. Today we have 94th session of our lecture series organized by ECG study group. And today's topic is wide complex tachycardia, incessant ventricular tachycardia, management strategies. And the lecture will be provided by none other than Professor Dr. Chowdhury H, Ahsan sir, Professor of Medicine, University of Nevada, Las Vegas. Before start of the lecture session, I'd like to request Professor Abdul Wadud Chowdhury sir to say some talk regarding this lecture and our presenter. Wadud Chowdhury sir.
Me? Sorry. Dear audience, today we're going to have fun with presentation of Professor Chowdhury H. His presentation I always enjoy. It's like seeing a puzzle and that you come to solve with the help of a lot of friends. Sometimes it will be infuriating because you cannot reach the diagnosis, but still at the end you will enjoy it. So without much ado, Professor Hafiz sir, the audience are yours.
ওকে থ্যাংক ইউ ওয়াদুদ। ওয়াদুদ হচ্ছে জাত টিচার, জাত শিক্ষক। So getting any compliments from a Jat teacher is actually huge. So thank you, Wadud. Let's see our patient, 23-year-old with no significant medical history, presented to the hospital with palpitation. And when we looked at the patient's hemodynamics, blood pressure was okay, but the heart rate was really fast. And this was the EKG. Any comment? It is kind of an open floor. So if there is any comment, we are not that many. Maybe we can unblock everyone. And then we can have a quick discussion. If not, then I'll move on.
Tushar,
Anyone to make
have to look in.
Yeah. So I tell my residents and
কামরুল
fellows,
ভাই,
yeah,
are you listening?
And
Yeah.
Thriti bolo.
monomorphic ventricular tachycardia, RBVB pattern.
so
Any other points?
So we heard about the diagnosis monomorphic VT, but I would say that before we jump on to any conclusion, maybe we can just say we all agree that this is wide complex tachycardia. And question is, it is regular or irregular? If this is VT, then the mortality is high, and it is important to find out what exactly it is and what kind of risk it poses to the patient's life. So QRS duration more than 120 millisecond, rate is high. But remember, wide complex tachycardia, there are other differential. It can be supraventricular tachycardia with aberrancy, and then it can be ventricular paced artifact, AV conduction with the accessory pathway, or it could be some channelopathy giving VT. So it is not just wide complex tachycardia and the patient is going too fast or hemodynamically unstable that really dictates, but we'll have to keep into the differential of the wide complex tachycardia. Rafique bhai is back, I see him. So therefore I'm going back to show the EKG. So this is what I called wide complex tachycardia. Is it regular or irregular? But if we look at V5, there is some irregularity obvious.
What is this black mark coming on the slide?
What?
Anybody
Oh.
else sees that? In my screen, the slide is partially
আমরাও
covered.
দেখতে পাচ্ছি যার জন্য লেখা এবং ইসিজি রিড করা যাচ্ছে না
Oh, black mark.
একটা
Oh,
কালার মুভ করে আপনার স্লাইড শো এর সময়
Part of it
I
is
am
covered
not-
by
huh?
part of it is covered by a big T or black, so we can't see it.
Because in my screen, I'm not seeing.
It has moved to a different location now. Can you read? I think you should share it.
Can see it now?
It still comes with that black shadow, so you can only
Oh.
see part of it.
I do have no idea. What? Can you see it now?
Worse.
স্যার আপনি আবার একটু রিশেয়ার করতে
Yeah,
পারবেন?
what about now?
No, it's still. Please reshare.
Okay, stop share and then
Yeah.
reshare.
Yeah.
Okay.
রফিক স্যার
What about now?
Same problem.
হাফিজ স্যার ইজ
এইটা বাংলাদেশের প্রেস ফ্রিডমের মতো সবকিছু ঢেকে ঢুকে দেখাচ্ছে।
Oh, because I don't know why it is. Okay, let me move to the next slide. Can you see it now? My slide?
Nothing wrong with your, we can only see part of it. It gets covered with a black something. And it's not just a black line, it's covering a big area of your slide.
Really? Because I cannot figure out anything. Maybe, so Rafique bhai, so this was a patient with wide complex tachy and with AFib and very fast ventricular rate, over 200. And question is how you tease out from the VT and AFib with accessory pathway, antidromic tachycardia. The reason I'm saying this, because can you discuss this little bit on this while I stop, leave and join again?
Yeah, we need the EKG so that we can talk.
Because I do not know why my screen is like that.
The question was, many a times we see wide complex, the VT initially there is some irregularity in the rate.
Yeah.
Why
So,
that so?
okay.
Okay,
So
can
this
you,
patient,
is this gone now? Is it
No.
coming good now?
It's a
No, sir, the same
persistent.
thing.
Huh?
Persistent. একই রকম।
persistent.
Oh,
এর কি রফিক স্যারের কাছ থেকে
আরিফ ভাই,
পাঠাতে
আপনার
পারবেন?
স্লাইডে
দেখেন।
আপনার
হ্যাঁ?
স্লাইডে ওভারশ্যাডো হচ্ছে আর কি, স্লাইডে ওভারশ্যাডো হচ্ছে,
overshadow মানে?
মানে স্লাইডের উপর আরেকটা স্লাইড ওটার উপর পেস্ট করা আছে আর কি।
At a
Oh.
black stuff that is covering the slide. And it's not a small, initially I thought you were trying to hide the name of the patient, but then
হ্যাঁ।
Rafique sir,
yes,
sir, the question was can VT be irregular sometimes?
yeah. So I'm going to come to that point later on. But this is a patient who came with the palpitation. I'm sure has been in the ER for at least 5 minutes before they got an EKG. So it's not something that actually it
How
just
about
the
now?
VT
Is it doing okay now?
same problem, but it's a little better. So when VT starts automatic focus, there can be some change in rate. But here, if you look at lead V2, it looks very regular. However, if you look in the bottom, there is definitely irregular. And that's basically AFib. When you look at V6, there is some variability in the QRS. And the first thing I'll think of is AFib with the WPW syndrome. That will be my first diagnosis.
And what is the irregularity in the VT world? You take the cycle length variability that Tushar pointed out. This is not as this much, because in V5, V6, it is pretty obvious. Look at the cycle length in V5, V6. It is very irregular.
Yeah, also in rhythm strip in the bottom.
Mhm.
It is much more clear in the rhythm strip in the bottom, the irregularity. In the VT, you will not get this kind of irregularity. You can get a pattern of bi-Gemini pattern. If you have a reentrant VT, it can happen. Or in the beginning, you can see some irregularity, but eventually it becomes regular. So the teaching is that if it is irregular, you don't completely rule out VT, but we have to look for something else. And this patient is hemodynamically stable. Okay,
So
go ahead.
for the ER management, you know, the best thing is that if you pray and then patient passes out or drops blood pressure, it is easy. You can cardiovert. But if the patient is alert, awake, it is difficult to cardiovert unless you convince the patient that I'm going to cardiovert and get anesthesia and cardiovert. The other thing is that if you want to give any medication, you need to keep in mind that the differential and what I call the dangerous differential. If it is VT versus if it is AFib with pre-excitation, because it is white complex and it is going to be antidromic tachycardia. So in any case, if you think about the white complex tachycardia, these are the summary of the overall white complex tachycardia. Paced rhythm and tachycardia, it is probably going to be easier. Pre-existing bundle branch and then tachycardia, or is it VT, or it is aberrancy with AFib, or is it a question about pre-excitation? Generally, and I would like to hear Rafique Bhai's comment, if the AFib is in the 160, 170, 180 ventricular rate, you still can entertain all these I have said. But if the AFib with ventricular rate in a young patient more than 200, and you see the every lead, particularly the rhythm read, and it is irregular, it is underlying pre-excitation.
Absolutely. I mean, that's very, very clear and well said.
So if you think about this, how we need to triage this patient, look at the EKG, look at the diagnosis, look at the underlying structure. And if you look at the lead, if there is irregularity in the size, and then my question is, what is the next management? We call it the Wolff-Parkinson's-White syndrome. These are the three gentlemen who describe this. And there are several of these pathways can give this, but for simplified understanding for general cardiology, there is two ways it can go from the atria to the ventricle. It can go to the orthodox pathway, or it can go to the pre-excitation pathway. If it goes to the pre-excitation pathway and comes back, it finds the pre-excitation from the atria to the ventricle, then muscle-to-muscle conduction back into the atria forms the circuit, and then it can cause white complex. But if it is going through the orthodox pathway, AV node, and then use the orthodox bundle branch Purkinje system, and then comes back through the pre-excitation pathway into the atria and forms the circuit, then the QRS remains narrow. So if it is white complex and we give something that blocks the AV node and the mechanism is antidromic, there is potential that it can get lost into the ventricle and generate this rhythm, ventricular fibrillation with death. So in a young patient, how do we assess that who in the young group with WPW may have higher risk for sudden cardiac death? And this patient presented with this antidromic tachycardia, very high ventricular rate, and we excluded structural abnormalities, such as there can be association with Ebstein's, hypertrophic cardiomyopathy, transposition of the great vessels. And once we do that, we are obligated to exclude. Then we need to see whether can we ablate. Because once he's cardioverted, now it is clear that there is short PR, and then there is this pre-excitation in the ascending limb of the QRS. We call that delta wave. And question is, before I go there, Rafique bhai, do you have any comment about when we see this in the surface EKG? There are plenty of literature now saying that you can somewhat guess where is this accessory pathway.
Yeah, I mean, it's true. I mean, the question is, from a clinical cardiology standpoint, it doesn't really matter. But if I'm going to take this patient to the EP lab, I want to have some idea of which side. We prepared it that way. So the algorithms are, well, you can look it up and see which side the pathway is at. One other thing that I would like to just mention that the first ECG, I mean, you will have this desire to call it VT, but as Hafiz said, call it white QRS tachycardia if we don't know, and then go through the differential diagnosis. So important.
And when the white complex is overwhelming, and sometimes our eyes deceive us, and it looks like regular, but if you are careful and pay attention, you will see that somewhere you will see that it makes sense to believe that this is irregular. And then you figure out that, is it possible that we are dealing with a pre-excitation with fast ventricular rate? That fast ventricular rate usually is above 200. So you can do this mapping and then figure out, and now it is much easier. But after the ablation, the EKG, the pre-excitation disappeared, and also we don't see the short PR. And let me, before you have any comment, maybe I can go to the second patient, then we can summarize this. So we had another young patient. Watch, both of our patients today are very young. And this patient came in with a very borderline blood pressure, but the heart rate was really fast. So we talked about the previous patient, similar age, very fast ventricular rate. This is another patient with also very fast ventricular rate. And I would request you that with this fast ventricular rate, maybe I should say this way, never read the ST segment. Because if you look at the ST segment in AVR, it will be panic, and it was panic in our ER. And I said, please, 22-year-old, let's not think about coronaries first.
Is this a Hispanic patient?
This patient actually is a Caucasian, Rafique.
Okay. I mean, I saw this ECG on a patient yesterday. Same ECG. Maybe it came from Las Vegas, who knows?
No, this is ours.
I know, but somebody called me yesterday. There's the same ECG.
Okay, so look at this.
Somebody
This
should, can you have
Yeah.
one of the participants say something about it?
Yeah. Open floor. So very fast ventricular rate. And there is right bundle branch morphology.
এই সাউন্ডটা ইয়ে করুন।
I'd like to say about this ECG. I'm
Yeah.
Dr. Govindo.
Yeah.
Govindo.
কেমন আছো?
এই তো স্যার ভালো আছেন স্যার?
মনে করেছিলাম যে দর্শক শূন্য টেস্ট ম্যাচ হবে আজকে, কিন্তু
না
না,
আমি
বহুত
অনেক
দর্শক।
9:30 থেকে অপেক্ষা করতেছিলাম, কিন্তু তো ওপেন করতে একটু দেরি হয়েছে মনে হয়।
62 attendee.
Yes, not bad. So Govindo,
62, হ্যাঁ স্যার। SVT with pre-existing bundle branch block, one of the commonest possibilities.
yes,
Because so fast heart rate, I cannot calculate, and
Right.
Probably 300.
but you give a differential.
Differential will be another possibility is VT, ventricular tachycardia.
Okay,
Any white complex tachycardia should at first ruled out ventricular tachycardia, all of we know. But here the ventricular tachycardia, some points in against a ventricular tachycardia so fast heart rate. Ventricular tachycardia usually এত বেশি heart rate সাধারণত থাকে না।
okay. So and then what about pre-excitation?
Another possibility, pre-excitation with only pre-excitation, that means
But I will tell you that in a situation like this, I usually use my slide calipers. And if you look at this, it is really regular. It is wide complex tachycardia and
Somebody
regular.
else raised hand. Abdullah Mamun.
Yeah.
Yes, sir. Assalamu alaikum, sir. Can I comment on this ECG?
Sure,
Yep,
please do.
of course.
This is the 12-lead surface ECG showing the normal standardization and calibration. Rhythm is seems to be irregular, and rate is about 270 or 205. And
Look
there
at the
is
computer. Computer is very good in calculating time and intervals.
Yes, sir. POF is absent, and there is, and QRS morphology is a variable. QRS morphology is a variable, and there is morphology is RBB, and there is left axis deviation. So my impression is this is irregular white complex tachycardia, most probably due to F with pre-excitation, F with WPW syndrome.
Okay, so let me
WPW.
correct you on that. So there are a few things. Facts we cannot alter. the intervals, RR interval is solidly regular, absolutely regular. Does it change your mind?
So
mine-
let me emphasize something. So if we
Yeah.
if we look at the rhythm state in the bottom, the cycle
It is-
length is 280 millisecond, at best 290. So there is a variation, but
variation.
it's no, but it's not that variation. It's
Yeah.
280 to 90. That's within the range of any pathway conduction. So if it is AFib, then it will be like 80, 40, 100 millisecond variation. It's not like that. It's by all definitions regular tachycardia.
So, Rafique,
Regular.
you will probably agree about this. Tushar pointed out this thing about the slide. So, 10 to 20 millisecond cycle length variability in the general cardiology world, we embrace that as regular, not irregular.
Sir,
and if you look at the calipers,
Okay.
Caliper measurement, it is actually regular.
Rafique sir,
Almost regular.
Sir, can I just make ask
Yeah.
Rafique sir for a moment? There is no clean-cut consensus on that rate variability about the millisecond. Rafique sir, is there many authors write
No,
it
no,
10 to
no,
20
no.
milliseconds? Sir, is there
Okay,
any
yeah.
written consensus?
No. Look at this. Look at it this way. Let's say there is a VT and it is going through the pathway. There can be some variation. Nobody knows what is the way, but if you look at this one compared to the ECG before, the big difference in the variability of the RR interval. This is subtle, and I can explain the variation, but that will be too much. But I think by all definition, this is a regular white QRS tachycardia.
Sir, is there any possibilities of a bidirectional VT?
No.
Okay, so Rafique bhai,
Yeah.
let me clarify this. So there is also a comment that
LVOT
there
BT
is
maybe.
the QRS morphology variation. We need to be clear in mind about the QRS, the amplitude variation, and then QRS morphology variation. QRS duration variation or QRS morphology variation. So I have a very late EKG in this presentation. When there is like a polymorphic VT, then you can see by definition, there is morphologic variation in the QRS. But in this EKG, the one that you are seeing, there is no morphology variation in the QRS complex, but there is the little bit of amplitude variation of the QRS complexes. And that can be present in AV nodal re-entry tach, and that can be present in the case of tamponade, and that can be present in terms of VT as well.
Can I make a comment on this, Hafiz?
Yeah,
I think we have
yeah.
talked. So right bundle, left axis deviation. Look at V5 and V6. RS ratio less than 1. That points towards VT, but how can it be? Initial part is so sharp.
Yes.
So let's assume an impulse is originating from the left posterior fascicle. What will it look like? It will develop a right bundle morphology with left axis deviation.
Yep. And,
All right,
that can explain, as Rafique bhai pointed out, the sharp QRS, because if the early part of the depolarization is prolonged, that goes in favor of VT because it is muscle to muscle conduction. However, exception is if it is using the fascicle, then it is taking the advantage of the orthodox conduction through the fascicle, then going into the muscle and then giving the VT. That makes sense? And this raises a question about whether this is a fascicular VT or not. So we cardioverted, and this is the EKG. So cardioversion is easy. After cardioversion, you go back and then now say, is it VT or SV? Was it pre-excitation or it was with SVT with aberrancy? Any comment?
Sir, as Rafique sir mentioned, the presence of RBB morphology with left axis deviation and RS ratio in V5-6 less than 1, typically from electrophysiology point of view, it usually dictates towards fascicular VT.
Okay. What I am saying to you, Tushar, that now that we cardioverted, you have the 12 lead EKG, you are what they call in US, the Monday morning quarterback. Now can you figure it out? What was the rhythm? Well, before we scratch our head and problem, this patient had this echo. Echo is not normal. And this is 22-year-old and has myotonic dystrophy and LV systolic dysfunction severely decreased. We also did the strain echo. You can see global longitudinal strain clearly indicative of systolic dysfunction. But before we had any breathing space, he developed more episodes of this wide complex tachycardia. What do you think? The rate is really fast and he was rapidly deteriorating. And he had several of this. Any suggestion? Tushar?
Sir, if we consider that these two ECGs, it's VT, we're confirmed it's VT, but the V1 morphology, the initial ECG, the V1, the amplitude and the morphology of V1, RB morphology has changed a bit. And other than that, rest of the things are more or less okay.
Yeah.
Only thing that has
And,
changed
you
is
know,
the V1 morphology.
And then, it is very...
Okay, can you go back, Hafiz, to the first ECG, please?
First VT?
Yeah.
Okay.
Okay, V3 looks like V1 now. Go to the next ECG. Somebody placed the V1 into V3. In that, look at the ECG. Go back, please.
Yes, I see that.
Now, I cannot see. We are not seeing it. We are stuck with the ECG.
Yeah. Can you see which one you are seeing now?
Now we're seeing the
second
third or fourth.
Second,
Can you go to the
one.
second ECG?
Oh.
So normal sinus ECG, the normal sinus ECG.
Normal sinus.
Sinus tachycardia as well.
Okay, if you look in this ECG, V3, V1R is prominent, which can be only right bundle. So V3, initially I thought, did this patient have an MI? Somebody swapped V1 and V3, and that explains why V1 in the first ECG and the other VT looks different.
Okay.
But why develop systolic dysfunction of this particular patient?
Well, that's Hafiz says would be somebody to tell us
And
what's
this
going on.
is just sinus tachycardia and develop.
That's why I'm telling you that as a clinician, we need to know the whole thing. Patient has myotonic dystrophy.
Dystrophy,
Yeah, myotonic dystrophy and this echo. So when I see this, it is very clear that this myotonic dystrophy, there is no other reason why this 23-year-old will have LV systolic dysfunction. By the way,
That-
this is Las Vegas, so we did exclude the toxic screen. There is no substance abuse. So
Right, this is-
what I'm telling you that after knowing that the LV systolic function is severely decreased, global strain showing that it is systolic dysfunction obvious, chamber dilatation, and this EKG now with recurrent episode of white complex tachycardia, what will be your working diagnosis? So they gave amiodarone, they get Lido. So when it happens, I tell my fellows that people become headless chicken. So because now we are trying to stop these VT storms and patient rapidly decompensated, then they put on intubation and then start levo and all that. So what I did is that I just took over the hemodynamics first. And I did a quick right and left heart cath. Remarkably, right heart is normal. Right heart pressure is good. I just give an impeller support. Patient is deeply sedated. And now rhythm is under control. What do you do next?
How can we define VT storm? How many times it will be occurred?
Okay, I'll come to that. But let's go through this patient first. And then I'm going to explain what will be considered as VT storm or incision VT and what are the initial things that we need to do. Because this patient with that LV, with that fast ventricular rate, could not tolerate and then went into profound hypotension. They started on amio lidocaine earlier and then intubated and then started on pressors. And there was escalating doses of pressors. And therefore, I wanted to give the hemodynamic support. But my question is, after that, we actually brought the patient to the cath lab, and you can see all these ablation catheters to see whether we can ablate. The question is, in a patient with this recurrent episode of VT, bad EF, is there any role of ablation? I can leave that question now for Rafique Bhai, or I can just show you that the patient, we did ablate on this patient, it was good. And then I wanted to show you that these two white complex tachycardia, we managed in two different ways. But if you ask me to say, when will you consider an electrical storm of VT or in a patient with the ICD, if the 3 or more episode of ICD therapies in 24 hours, is called the electrical storm. And if the patient does not have ICD, our patient did not have 2 unstable events in 24 hours, or you cannot control the VT for hours. One of the common thing you may see more often is the, in a coronary ward is LV aneurysm and incision VT. Or you may have ischemia scar and incision VT. But in case of purely ischemia trigger, you may see polymorphic VT, but there is no Bible rule that ischemia only give polymorphic VT and scar only gives monomorphic VT. The problem with the electrical storm that it can be highly lethal. So if we don't take care of these patients, that can be an impending doomsday. The another important thing, the more we shock this patient, there is more stunning and there is more deterioration of the LV function.
Pardon me, can I ask one question, sir?
Yeah.
Sir, so far I know theoretically the stellate ganglion ablation, one of the modalities of VT storm.
Okay,
Is there...
so Govinda, you are going too fast. And yes, that is one of the way to treat. And I will tell you when that we need. I sent a couple of patients to UCLA with Dr. Shiv Kumar. He is the editor-in-chief of Jack EP. You probably know him. And he did that for me. The one patient was actually working in Las Vegas airport, and it's incision VT. We did all workup and then had a stellate ganglia intervention. But I'll tell you that who are supposed to get this incision VT? Patients, you talked about bidirectional VT. Digoxin toxicity is notorious, but you get QRS in one beat in one direction, other beat in another direction. That's why it call it bidirectional VT. But absence of revascularization, then an aneurysm, renal failure, all these can be a trigger. And this VT morphology is important. But the problem is that when it is drugs, like licorice injection, digoxin toxicity, this bidirectional VT ischemia trigger or bradycardia pause-dependent polymorphic VT, they all can ultimately degenerate into ventricular fibrillation. And it is important to realize that whenever there is electrical storm and you are shocking, the more you are giving shocks, the worse is the downline prognosis for these patients. There is this references, and I can give you the references, you can read it. But the bottom line is that we really need to think that why this is happening. And to answer Govinda's question, that we need to look at what is the substrate, what is the trigger, and whether there is any autonomic dysregulation. Autonomic dysregulation can be a factor. It is not that common, but yes, if that is the issue, sometimes we may need to go for as aggressive as going after the stellate ganglia. But most common in our adult world is the middle group, the ischemia, the electrolytes, the heart failure, cardiomyopathy, like in our patient with myotonic dystrophy is well known. And then inflammation can be a problem, and you can get giant cell and non-giant cell myocarditis, and of course, drug related. And if you look at the vast majority of our patients with known coronary disease, the aneurysm scar on the left side can be a big substrate for giving rise to this phenomena of VT storm or incision VT.
Sometimes myotonic dystrophy associated with the cardiomyopathy as well.
So that exactly the case, right? The patient did have myotonic dystrophy known and did have cardiomyopathy known. And what happened that people do not look at even the point of care echo is good. And if you see the point of care ultrasound in a 23-year-old, LV is dilated and there is a known myotonic dystrophy, you need to do the math that 2 + 2 is 4. It is not new. And this happened because in the myotonic dystrophy, or for that matter, any cardiomyopathy, any scar can become a substrate and initiate this VT storm. Question is,
sir, another question, sir. Excuse me, sir. Can we go for anti-failure therapy after uprising of blood pressure or stabilization of the blood pressure? Can we go for Fantastic 4, ARNI, SGLT inhibitor, other anti-failure drug that can increase the systolic function and also cardiac function improvement?
Yes, of course. And of course, that will be the standard of care and to help. However, when the patient is in the middle of a storm and following shocks, LV is now stunned even more, and hemodynamic instability, we need to bail out. You need to bail out from that situation so that you can stabilize and then give the therapy. It is not either or. We need to look at the acute situation first.
Thank you, sir.
Yeah. So, and then once we get this under the control, and then we can think about, take a pause and think about what is the issue going on. But we should always keep in mind that in a situation like this, there is a substrate, there is a trigger, and there is an interplay with the autonomic dysregulation. And we can chase those, and then we can get this. Now, in the bottom of this slide, you can see we are talking about early after depolarization and delayed after depolarization. Typically, bidirectional VT is in the problem with the delayed after depolarization mechanism. But this is a list. And as you pointed out, in giant cell myocarditis, if you don't address the inflammation, you may end up with conduction problem, maybe bradycardia, complete heart block, and also concurrent VT at times. And in that situation, you give the electrical support. We give in our patient, not only we give the mechanical support to get the electrical instability under control, sometimes you do both. You give electrical support and also you give the mechanical support as needed. And then you think about what is going on. The underlying pathophysiology address is very important. We had a giant cell myocarditis, we had to give the immunosuppressive agents and all that to get this under control. So bradycardia and bradycardia related variability in QT prolongation in Tushar is very well known to all of us, and that can present and can be a vexing problem. And whatever it is, we need to use in collaboration with our colleagues from different specialty. It is easy when it is electrolyte imbalance or some underlying issue we can figure out. But I think it is important to assess the patient in terms of very basic EKG history, physical exam. What is the underlying cardiac conditions, any other significant comorbidities that we can relate to initial lab. Patient, for example, in recurrent VT storm, cardiogenic shock, but you are too much late in the game and the pH is 6.9, lactate is high, you need to think about whether we address this or accept this as acceptable death. What can we do? But in a young patient, you need to really think very carefully whether we can bail out from this electrical storm, give the mechanical support, and then we can save the patient, and then think about what to do for the underlying issues, such as Dr. Govindopal mentioned about instituting the therapy for cardiomyopathy. The device programming sometimes may help. Rafique bhai, do you have any comment about this patient had a pacemaker and now coming with, long QT, electrical or change with drug in use? Then we can probably pace the patient faster. Or if the patient doesn't have a pacemaker, we can pace by a temporary pacer. Any comment, Rafique bhai?
No, I think that's what we will do at the first step. You wait for the drug to wash out.
Yes.
And until that time, increase the rate to 80, 90. I'm probably go for 90 or 100 beats per minute.
Yeah. And any comment, Rafique bhai, about this use of antiarrhythmic in a VT storm? Particularly, we sometimes see that we use amiodarone and lidocaine in combo. And procainamide, I reserve this if we have a suspicion or high suspicion for pre-excitation, then it is a good thing to have in our armamentarium that we can use procainamide IV. In Bangladesh, I don't know what antiarrhythmics intravenous that's easily available. at bedside, at least in our major institutions. I would like to hear any comment on those.
Sir,
The procainamide is the best drug for WPW syndrome with AFib. Unfortunately, even in US, it's difficult to find in the pharmacies. And my understanding is in Bangladesh, we have IV amiodarone and IV lidocaine. Is that right?
sir, IV amiodarone, IV lidocaine, and sometimes we find also IV esmolol, but that esmolol is not that much available. We get some local market, we get some esmolol from market, which is recruited from India, but not.
Our country, propafenone also available. Propafenone or procainamide.
No. Propafenone is not
Ridmocin.
available. It's oral. Propafenone orally is available.
Yeah, orally available. Yes.
Sir, for
IV
IV,
not available.
that amiodarone and
Now, IP beta blocker available, metoprolol available.
Okay. So, and you can see that I mentioned this, what is the agents for the adrenergic blockade. But another thing to consider, and I will tell you to seriously consider that if it is an incision VT, then you can just intubate, sedate. That may help. That really may help, because, and then you can sort out, and if you are lucky, you can be able to keep the hemodynamics with a small dose of norepinephrine.
It's due to electrolyte imbalance, dyselectrolytemia for incessant VT, then correction of this electrolyte imbalance. So
Absolutely. Other potassium and magnesium correction is very important.
Yes, sir.
Yeah. And then if the underlying issue is ischemia, then it is not a bad idea to think about how we can give the little bit of a diastolic perfusion in the coronary and may help. But I tell you, and it is our experience, that in a incision VT, particularly not polymorphic, and it is not manageable, electrical deterioration leading to mechanical deterioration, and sometimes mechanical deterioration giving electrical deterioration, then you really need to do a quick hemodynamic assessment, right heart cath, and bedside echo, and then mechanical circulatory support. You can bring it early on to help the patient. So because of the time constraint, I wanted to show you a good case for discussion, because it was really a puzzling situation for us. But I wanted to show you, Govinda, you mentioned about this. We had a step-by-step assessment and what to do. And yes, your choice of this, the stellate ganglia is there, but it is really not the first line, second line. It's really reserved for the late patients where we have exhausted other situations. Okay. So let me go through this slide, and then I'm going to show you the case presentation. The electrical storm. So as I said, it is very important that we have a comprehensive assessment of the patient, not by just one group, meaning it is unfair to give it all to the electrophysiologist, and it is also unfair to give it to the general cardiologist. It is also unfair to give it to the interventionalist. We should all work together in that situation. And you can see, and this is a literature published, that if you are thinking about who goes into this storm and will deteriorate, you can look at the Spain's SD studies where they did the risk score. And if you are going to the cath lab without proper thinking, those who have high risk score, they will deteriorate in the cath lab. So our electrophysiologists, they talk to us and we help them to give the hemodynamic support as needed. And it is better, and I emphasize, it is better to do preemptively, better plan, better preparation than ad hoc mechanical bailout. And as you all know, and all of you are following the literature, in the mechanical circulatory support world, the use of mechanical circulatory support as bailout after the fact, after the intervention, you don't see that much benefit and you blame the mechanical circulatory support. But with the danger shock published, and now we have analyzed our data that if you do a planned procedure, high risk or already in shock, but you do the support first, not bailout.
Is there any role of, sir, is there any role of ECMO?
Okay, so I am saying about mechanical circulatory support. So Impella is one of the device for mechanical circulatory support. When you do the assessment for mechanical deterioration, heart as a pump, you need to do the right heart and see what is the problem. Is it LV shock, RV shock, BIV shock? And of course, you exclude any valve disease and any constriction, restriction, or any pericardial effusion. These are very basic, but grossly speaking, LV shock, RV shock, and BIV shock. If it is BIV shock or predominantly RV shock, then LV Impella is not going to cut it. And if it is BIV shock, yes, you may need to give a VA ECMO with the LV vent. So it's a VA ECMO and Impella. So you need to understand the hemodynamics before you go to the war, and then choose the device appropriately to give the support. But that is, Govindo, a whole another talk. So with these two cases, let me give you this so that we can finish quickly. 72-year-old, significant issue, CKD, hypertension, diabetes. Patient is also blind, initially stabilized, blood pressure was low, and then somehow we got the patient stabilized, sepsis kind of ruled out, and platelet was 180 at baseline. Look at the kidney function, 3.9, 3.7, and then this EKG. Sinus rhythm, right bundle, left axis, and then little bit of rate acceleration. And then after a few days, the patient coded in the ICU with this. Any comment? What is happening? So Rafique bhai asan naki? Any comment Rafique bhai?
Baseline ECG ke bundle branch chilo na?
Bundle branch chilo. Right bundle, left axis.
Yeah, so basically it's a patient now goes into intermittent heart block.
Yes.
Because the two P was missing.
And then lots of P's, less QRS.
Yeah.
And then comes back, we got him back, and then starts doing this. Like cardiac standstill, P waves, but no conduction. And then P waves, no conduction.
Just previous ECG, sir, just previous, one previous ECG.
Yeah, right bundle, left axis.
Sir, Rafique sir, please, this regarding this ECG, like group bit.
Well,
what is happening?
I mean, if you start with the first one, first QRS, second QRS, it's difficult to say it conducted or not. It can be an escape bit, but the third QRS most likely is conducted because it advanced. And then I don't know if there is a one in the middle. So that fourth one is going. So basically it's going, initially there is some Wonkeva pattern, but it's high grade AV block, the whole thing. You have to look at a long rhythm stream to come up with a pattern of this one.
And I will request everybody to watch that how Rafique bhai described the EKG. He's looking at the atrial repolarization. He's looking at the ventricular repolarization. Then he's trying to figure out the relationship between the atrial depolarization and the ventricular depolarization. He already knows that the conduction system is jacked up because right bundle and left axis. That means there is Purkinje system problem, the jacked up conduction, and then relationship is becoming very unreliable. It is almost going into divorce between the atria and the ventricle. And then there is complete. The atria is kicking in, showing the depolarization, but no ventricular. So it's like a ventricular standstill. And then further, and then in the middle panel, occasionally ventricle is waking up, but the atria is just doing its job, atrial depolarization. So what do you do next? So we did a pacer, initially transcutaneous, then brought back to the cath lab, and then we do this temporary wear, and now the patient showing this. Any comment?
What's about potassium electrolyte?
Potassium, magnesium, I love you, Govindo. You always go to the basic. Potassium, magnesium corrected, acidosis corrected.
Thank you, sir.
So now this is a shock, and then blood pressure drops. Now we give hemodynamic support. Now the pacer is okay. Are you happy?
Yeah.
Okay.
One question
Now the pacer is there. And now this is happening. Patient went to the CCU, pacer done. Few hours later, there's blood pressure drops, goes into this rhythm. White complex tachycardia. For sure. Question is, what do you do? So we did another potassium because the QR is a little widened. We checked the blood gas, correct this, but potassium was okay actually. So hemodynamic unstable, and now in a multidisciplinary meeting, the lactate and all this, they said that no, we need to go to the cath lab. And I said the prognosis is bad. So I did do the right heart, left heart, try to understand the cardiac power output, and then pulsatility index for the PAPI, and look at the hemodynamics and see what will be the best thing. Patient, of course, is intubated. He's doing this in the cath lab. And then I quickly do the right heart. And then ultimately was able to do a quick left heart injections. And I was thinking about not to do anything further, but our ICU guys were really insisting. And this is what I call it. If it is raining, you go out, you get wet. Because it was so obvious. Patient has all the risk factors in the world. And then you do cath and you get this. And I don't think that we have any surgeons in our group here, but everybody will throw towels. So this is what we did. We put we talked to the family and all that, hemodynamic support, and then we did the rota of the left main. It was a really, really high risk. Rota bar was almost going to stack. I did some unique techniques, and ultimately we just kept it simple and take care of this significant ischemia, but did not go for complete revascularization. The VT storm was helped, and then ultimately we were able to wean off pressors, and then kidney deteriorated, ultimately needed dialysis, but with a small dose of dobutamine with PICC line, and then keeping the patient alive. Patient went home last week after 11 days in the hospital. So that was the story with the recurrent VT following the bradycardia complete heart block in a pre-existing patient with significant conduction disease and, as you noticed, significant LV dysfunction in the setting of significant left main and multivessel disease. I'll stop there and we can take some
It's a
questions.
wonderful presentation. One of the things that you have to pay attention that what Hafiz said, that when a patient like this comes, it's not one person working. It's everybody is involved, one person in charge. One person coordinates and we don't give up on the patient. We just don't leave home. Unfortunately, interesting part is that even if we go home, we take the patient with us in our brain. And so that's the key, that one of the things that Tushar asked, the variation in RR interval. I just looked it up a little bit, and there are different studies was done. And when the R2R variation was more than 20 milliseconds in VT, it was considered as irregular VT.
Yeah.
Second question was comparison between AFib and VT. Most VTs will be, if it is irregular, to less than 40 milliseconds. And AFib will be more than 40 milliseconds. So this is but you have to also understand that if somebody is AFib and getting isopil for some reason, that irregularity may change. We're talking about a patient who is reasonable, or somebody who is in a shock and in AFib, the irregularity may not be as obvious. So that's the basic way that it is done. Okay.
So let me also, Tushar, to answer your question, that's why I showed these cases. Let me cheat a little bit. And in clinical medicine, cheating is allowed. What I mean by cheating, that in the first case, if you look at the patient doesn't have any prior cardiac history. No myotonic dystrophy, no cardiomyopathy. He's 22. The second patient is 23-year-old, but he does have myotonic dystrophy. And then if you look at the quick bedside, LV is dilated in the second patient. And then in the first patient, LV is not dilated. So then if you take this into totality, and your brain will tell you that the likelihood of VT in the first patient will be very negligible. Whereas in the second patient, it is VT until proven otherwise. In a bat pump with white complex, it is VT. A patient with previous cabbage, stents, LV dysfunction, white complex tachy, it is VT until proven otherwise. Unless you can be vigilant and quickly look at in the, we have all electronic medical record. I tell the fellows and residents, always look at Epic Anywhere and previous medical history and EKG. If there was a left bundle before and now coming with white complex, it can be high up diagnosis that it is SVT with previous bundle branch. And if it is irregular, maybe AFib. But if it is not irregular, it could be a VT, but it has to change. The left bundle morphology and the axis has to change because it is a different source of coming this from the ventricle. That is my very basic way of figuring out the electrical. But then if you can't figure out, then you ask for the EP physician as you are managing the patient.
Can I comment, sir? Can I comment, sir? স্যার বলেন স্যার
So cheating is allowed.
আমি একটা মজার জোক বলি।
বলেন স্যার।
জোকটা সত্যি ঘটনা, কিন্তু এই ছিল না,
কোথায় স্যার?
শিল্পী আমাদের ইন্ডিয়ার বাংলা গান গায় শিল্পী হলো, তার নাম হলো
লতা
না, ছেলে
ও ছেলে ও
শ্যামল মিত্র। তো শ্যামল মিত্র কিন্তু খুব ভালো রবীন্দ্রসঙ্গীত গাইতো।
জি স্যার।
তারপরে একটা এতে সে রবীন্দ্রসঙ্গীত গাইলো, তখন যারা রবীন্দ্রসঙ্গীত শুধু গাইতো তারা এসে আস্তে আস্তে বলল, দাদা আপনিও যদি রবীন্দ্রসঙ্গীত গান তাহলে আমাদের চলবে কি করে?
চৌধুরী আহসান স্যারকে বলা হইলো নাকি স্যার?
না বললাম ঠিক।
That was probably one of the best compliment I ever had.
Nah, this was a good.
I agree.
This is a wonderful presentation. It's a multidisciplinary presentation, especially in Govinda bolo.
আমি বলতে চাচ্ছি যে যখন উই আর ইন কনফিউশন দা আইদার প্রি এক্সাইটেড এফ হেমোডাইনামিক আনস্টেবল বিটি হেমোডাইনামিক আনস্টেবল এসবিটি উইথ প্রি এক্সিস্টিং বান্ডল ব্রস হেমোডাইনামিক আনস্টেবল ডিসি কার্ডিওভার্সন একমাত্র চয়েস আমার তো ওইটাই তখন তো আর আমার ওই ডায়াগনোসিস করার তো আর কোনো টাইম নেই আমাকে তো তখন ওই গো ফর ডিসি কার্ডিওভার্সন এটাই আমি বলতে চাচ্ছি
না গোবিন্দ আমি একটা কমেন্ট করি হাফিজ
হ্যাঁ
কথাটা হলো কি রোগী দুইটা আসছে একটা ব্লাড প্রেশার 120 আর একটা ব্লাড প্রেশার 90 question is am I going to panic so if the patient is hemodynamically unstable it doesn't matter whether it's a narrow or wide QRS tachycardia you'll have to cardio
Yes,
however if the patient is stable just because the heart rate is 200 ও কিন্তু আসছে হাসপাতালে গান গাইতে গাইতে খালি একটু খারাপ লাগছে ওই জন্য হলো তখন একটু সময় আছে যে আমরা অনেক সময় ডাক্তাররা কিন্তু প্যানিকে হয়ে যায় আমাকে ওই দিন এক রোগী বলছে যে ডক্টর আহমেদ আমি সে গেছে এসভিটি নিয়ে হার্ট রেট 220 মহিলার সিমটম শুধু পালপিটেশন সে বলে ডক্টর আহমেদ when I listen to the doctors I got panicky because they were panicking
রোগী ইজ ওকে বাট ডক্টর ইজ প্যানিক
সে বলছে আমার ডাক্তাররা এত নার্ভাস হয়ে গেছে যে আমি তখন আমার মনে হলো এই তো আমি গেলাম মরে
Sir, there is another confusion sometimes happen, if I may add. During tachycardia, even when there is SVT, sometimes many places the measuring technician, the nurse, they report it as pressure is we can't measure the pressure. Or sometimes even the doctors may fail to measure the pressure and they say patient is in shock. Although the patient is normally with full sense. So that times there is some panicky situation happens.
Yes, BP recording is one of the most
আমি একটা
important.
গল্প বলি রফিক ভাই এই গল্পটা একটু ইম্পর্টেন্ট আমি যখন মেডিকেল স্কুলে তখন 5th ইয়ারে তখন আমার রুমমেট কয়েকজন রুমমেট ছিল তার মধ্যে একজনের কথা বলবো উনি আবার একটু হাইপোকন্ড্রিয়াক ছিল আমি ওনারা দেখতে গেছি উনি দেখি উনি ট্রেন্ডিলেনবার্গ হয়ে শুয়ে আছে আমি বললাম যে কি ব্যাপার আপনার কিরকম কেন বলে হাফিজ আমি শকে আছি তো whether somebody's blood pressure is what if the patient is walking talking mentation is good it is your problem as Rafique bhai pointed out but I also would like you to note what Rafique bhai said panic and I think one of the reason we panic when we don't know what is going on so if we know and we are familiar with these strategies that I have this plan A plan B plan C then we would not panic but Rafique bhai fantastic that yes I would be nervous if my doctors are panicking then like if I go to God forbid to an oncologist and they are looking at each other then I would be really panicky one question I want to answer there is a question in the chat box about MRI yes cardiac MRI can be a very good tool about a scar but it also there are studies looking at the scar burden and the VT burden but in some other diseases like we presented in this forum about RV dysplasia and VT in the young the MRI may have a role but in a acute situation and I tell these fellows do not mention about these things about MRI patient is not able to go to the MRI you need to take care of this patient first before you become a scientist.
Thank you, sir, for the very excellent and well demonstrated cases. It's almost close to 11 p.m. in Dhaka. So we are at the fag end of our program. I'd like to request Professor Abdul Chowdhury, sir, to wrap up the session and say something regarding the presentation. Abdul Chowdhury, sir.
আসলে হাবিবের প্রেজেন্টেশন সম্বন্ধে বলার কিছু না আমি যা বলছিলাম তাই মানে এনজয় করতে বসছি আমি কিন্তু খুব এনজয় করছি তবে যেটা বললেন সেটা প্রবলেম হলো যে আমাদের দেশে এই পেশেন্ট গুলাকে আমরা আসলে ধরে নিই we are not going to be able to come out victorious. The point is how much actually you are going to intervene. If we become hopeless at the beginning, that's the wrong thing. Many cases, if you, as Gobindo said, if we point to the basic things, what is the electrolyte, what is the underlying ischemia reason, or is there any scar, or is there any cardiomyopathy, we can actually decide to do something. And it's better to try than not to try at all. Abdul bhai, thank you. চিকিৎসা যে আছে এবং কত রকম আছে কি করা সম্ভব এবং কেন করব, কি করলে আমাদের আউটকামটা ভালো হবে, রফিক স্যার এবং আপনাদের যুগলবন্দিতে সেটা আমাদের কিন্তু খুব ভালো করে একটা উপলব্ধি হলো। উপলব্ধি তীব্রতা এখানেই বেশি যে আমরা কত কিছু করতে পারি না। এক সময় হয়তো আমরা
we can hope, Wadud, because with you and many others in the charge of leading institutions of Bangladesh, at least we have few places where we can have the state-of-the-art technologies so that we can teach our junior colleagues, and also we can make the technologies and the knowledge available for better care of our patients.
Right person in the right position. Again, congratulations, sir.
একটা কথা বলি যে কালকে আজমের সঙ্গে কথা হচ্ছিল আমার, আমি বললাম যে দেখো বাংলাদেশ, আমরা অনেক সময় মনে করতাম আমরা খুব বড় লোক দেশ, কিন্তু বাংলাদেশ স্টিল এ পোর কান্ট্রি। আর এখানে আমেরিকা থেকে আমরা কথা বলছি, দিস ইজ দ্য রিচেস্ট কান্ট্রি উইথ ইন অল রেসপেক্ট। সো ইভেন আমেরিকাতেও আজ থেকে 5 বছর আগে আমরা রুটিনলি এমআরআই করতাম না, ভেরি সিলেক্টেড পেশেন্ট। এখন আমরা করি, ইয়াং রোগী আসলে নন সাস্টেন বিটি হচ্ছে, একো করছি, সবকিছু নর্মাল উইডিও কার্ডিয়াক এমআরআই। সো ইউ হ্যাভ টু লুক এট দ্য হিস্ট্রি দ্যাট and the cost effectiveness of any treatment, what is available. এই জিনিসটা এই কথা। আরেকটা জিনিস হলো কি যে একটা লোককে হঠাৎ করে যদি বলে যে এমআরআই যদি থাকতো তাহলে বোধহয় আপনি বেঁচে যেতেন, কথাটা হলো কি, এইটা করলে ওই রোগীটা এমনি হয়তো মারা গেল কিংবা কিছু হলো না, বলবে যে আমার বাপে যদি এমআরআই থাকতো তাহলে আমার বাপটা না। তো অনেক সময় যেটা অ্যাভেলেবল না ওগুলো নিয়ে রোগীদেরকে মানে ডিসঅ্যাপয়েন্টেড না করা অনেক সময় ভালো আর কি একদিক দিয়ে, উইথ দ্য হোপ দ্যাট ওয়ান ডে। এক সময় তো বাংলাদেশে সিটি স্ক্যানার ছিল না, কিছুই ছিল না, আমাদের সময় তো ইসিজিও ছিল না। এখন সিটি হয়, এমআরআই হয়, এবং কলেজ কোয়েশ্চেন ইজ নলেজটা অ্যাকোয়ার করা। আরেকটা জিনিস খেয়াল করবা যে হাফিজ পাঠাইছে লস অ্যাঞ্জেলস স্টেট গ্যাংগ্রিন ব্লক করার জন্য। আমরা এই কাজটা করি, আমাদের রিজিওনালি উই ক্রিয়েট স্পেশালিস্ট এবং তাদেরকে আমরা সাপোর্ট করি উইথ কেসেস, so that they also develop expertise. এই যে কোলাবোরেশন, যে আমরা কম্পিটিশনের কাছে আমাদের কেস পাঠাই, যখন বল্টিমোরে লিমিটেড এমআরআই হতো, আমরা সব পাঠাতে জনস হপকিন্সে, যদিও আমরা তাদের কম্পিটিটর ছিলাম। কেন? যে ওরা যেন ওই কার্ডিয়াক এমআরআই এর স্কিলটা ডেভেলপ করতে পারে, এবং উই ওয়ার্ক কোলাবোরেটিভলি। এইভাবে টেকনোলজি ডেভেলপ হয়।
Thank you, Rafique bhai.
Thanks.
ঠিক আছে স্যার।
Thank you, sir. Thank you, Hafiz bhai.
Good to see you all again. Thank you.
আমি স্যার কিন্তু পার্থ অস্ট্রেলিয়া থেকে স্যার জয়েন করছি।
Nice. So anyway, Wadud,
স্যার,
congratulations.
Thank you, sir.
You are the right person for the job.
again congratulations
তোমাকে
স্যার।
2 দিনে একটু বয়সটা বেশি মনে হচ্ছে, যদিও দেখি আর
আমি তো বলছি স্যার যে অল্প কয়েকদিনে আমার মাথার চুলগুলো সব সাদা হয়ে যাবে, আর নইলে স্যার হয়ে যাবে, মাথা খালি হয়ে যাবে।
তুমি প্রেসিডেন্ট ওবামার কাছে শুনো যে তা কিভাবে চুল সাদা কম রাখা যায়। তার চুল অনেক সাদা হয়ে গেছিল, এখন হি হ্যাজ লট অফ এক্সপেরিয়েন্স। থ্যাংক ইউ।
আচ্ছা, রাখি, বাই বাই।
Have a good night, sir, all of you, sir. Thank you, sir.